When I've looked at the literature about what's going on in terms of economic analyses, most of it is about the burden of AMR or how it benefits agriculture. This is kind of interesting observations. So the first tranche, the first sort of level of analysis, the dominant analyses are around that. When it comes down to how antibiotic use in human and animal health is driven by economic factors, it's not so clear. It's not a well-developed field, so, there's lots of scope there. And here we start to see some complexity. There's not a clear story coming through. So some studies show that, the richer, the more affluent a community is or an individual is, the more likely they will be using antibiotics unnecessarily, which is interesting. Other studies are showing that it's associated with economic disadvantage, so lack of knowledge, poorer prescribers, over-prescribing because they're worried about the health status of excluded populations. So there's more to be teased out there. There's complexities about context and economic systems and how people prescribe. There are also marked difference between high and low income. So we know that places like Pakistan are reporting that nearly all antibiotics are off prescription. How that happens, we need more depth. When we look in high income settings, though, we're also seeing remarkable differences. So Australia, UK and the Netherlands differ a lot in terms of the quantity, the kinds of antibiotics that are being used, both in primary and hospital care, etc., and so forth. So, antibiotic use is not just explained by the kind of income level of population. It's sort of an interesting observation. There is some ethnographic material coming through which offers further insights, but it doesn't really resolve the issue. So using Thompson and Chandler's idea of, antibiotics as part of economic infrastructure, the benefits of antibiotics are economic in terms of saving costs to the health system, keeping people at work and so on, and also have value in agriculture. So that to the extent that farms are sites of value production and antibiotics are used in that context, antibiotics gain, value, economic value. They are infrastructure. I was quite interested in exploring this literature, so looking at ethnographies with dairy farmers in the UK and how they use antibiotics and how they, milking machines increase production, but milking machines damage udders and predispose udders to infection, so therefore antibiotics have to be used. This kind of self-driving system of economic production of risk, and antibiotics as the solution. Another little glimpse here is that Bangladeshi farmers reporting that they were obtaining their antibiotics on credit. So the ways in which in low income settings, the productivity of agriculture is enmeshed with systems of credit and debit. It's kind of interesting to think that through. And I suppose what all of that's revealing is how complex and nuanced this relationship between antibiotics and economics actually is. I quite like this work from Mozambique. So it's a kind of sociological study looking at how prescribing happens in an emerging economy. And they're definitely thinking about the kind of very local and multi-layered issues around the different factors that are kind of impacting on antimicrobial use. So the more we look, the more we follow the money, the more complex things become. So I've done this preliminary analysis to try and understand what our interviews say about this domain. And I've kind of got three main themes, and they've got elements within them. The first is around how consumers and providers are very reflexive with costs of healthcare and the costs of being ill and the costs of antibiotics and the complexities there. So another set of issues around the organizational context of the prescriber and how they work and how that impacts on their prescribing decisions. And then long term, I've very pretentiously called this longue durée, but I guess it's the macroeconomic issues that are framing these other issues. So there are glimpses in the material across these three levels, which are really interesting. So firstly, to reflexivity and costs, and I'll just, read out these quotations because I think they're kind of cool. So this is Dr. Madison, early 50s, very experienced, out there in outer Melbourne. And then they run a family and private clinic with gap fees. And in this, they're talking about, how they think about what they do necessarily involves money. If they've come in with a sick kid and it's a fairly undifferentiated problem, I say, look, we need to see them again in 24, 48 hours. And we would mostly bulk bill that consultation, because I think that really is a barrier for our patients. The other reason is sometimes, the parents are under pressure to be at work, to get the kid back to the childcare. So the conjunctivitis one, it's like, well, they can't go back until they've had drops, and, well, they don't need drops. They say if you give them drops, they're allowed to go back and then I can go to work because they're perfectly well. So those sorts of things are hard. I think financial pressures is one, time pressures is another. I think the financial stuff is the main thing, financial and the time. So this is a perspective on the antibiotics as economic infrastructure coming through in this story. This is a community member, a consumer, a younger man, also living out in the outer suburbs, working in a trade, not university educated, which is interesting. So listen to how he talks about this situation. I think Arjun is saying, what is your experience been like in the prescribing clinic? And this is what Mr. Maxwell says. Have you heard the expression, Dr. How long? So Dr. How long is a piss take. It's a reference to a bulk billing GP. You can go to a bulk billing GP, right, and ask for a medical certificate. And he'll say, or she will say, how long do you want? How much time do you want off work? How long? So, that's what we do to fake a sickie. So it's Dr. How long? You go into a GP and they basically give you a script that says you can have a week off work, right? Hence the expression, Dr. How long? He's making sure he's clearly understood, obviously. Dr. How long is a reference to a bulk billing GP in one of those clinics. It's such a bulk billing, it's such a massive operation. They haven't got time to provide good quality care. Well, the perception is that they haven't got time to provide good quality care, because why would someone who's basically working for the Medicare rate when other GPs would work for twice as much? And that thing frustrates me too, that we have to be in the situation where I've got to pay $40 to see my GP because she provides good quality care, when I can go and see Dr. How long and be bulk billed and get shit care because it's quick and they don't see the same person twice, and it's just the whole bulk billing massive operation. Now, this is a very strident account of, and I'm not so much interested in whether or not this is a true account of what's going on out there in the world. It's that this particular individual is very reflexive with these contexts and the kinds of care he's getting and the ways in which cost is figured into this narrative. So in this context, prescribing is deeply embedded with issues around cost. Then let's look at business rationalities. And this is where the I'm not a shop narrative comes through. So Dr. Ross is young-ish and works in a private clinic in inner Melbourne. So a different group of people coming in. And they're talking on the impact of the shift away from bulk billing. And they're giving a story about how other people have intervened into a decision. and how complex that has been. The practice manager recently joined the team, and the practice had changed from being a bulk billing practice where everyone from the hospital just went in and got seen and treated, into a place where patients had to pay. So they lost a large amount of their patient population because people were not used to paying. They didn't want to pay. So the practice manager's approach was to keep everyone super happy and give them what they want. Whereas my approach is that I'm a doctor, I'm not a shop. I'm happy to assess you, but I'm not happy to give you what you think you need. I'm happy to work out a plan with you. So her approach was basically around keeping patients and making sure that the patient population wouldn't drop further. But I don't think that's a good reason to do medicine. That's not according to the guidelines, or actually not really helping the patient. Another story, similar but different, and I think that's interesting. So Dr. Ricardo is a vet, also inner urban, and we're talking about their experience of having worked in different clinical contexts. When I've sort of been working for a family-owned business, it's not too bad, but often there's a few little suggestions here and there that, we should be selling more products. And antibiotics could be one way of increasing, a little bit of revenue here and there. But it's not, you could argue, I guess, in some cases, that it's not going to do any harm to the pets. And it may make things better because some of the antibiotics have an effect on the gut, for instance, where it's going to look like it's actually helping because of the way the drugs work. But the antibiotic property is not really doing much for the bacteria in the gut and helping in that regard. But there's a bit of pressure in that way from a lot of the corporate clinics. They look at figures and numbers. And if you're not pulling in a certain amount of revenue per appointment, they want you to try and do a little bit better. And like most corporations, it's just always trying to get you to do a little bit better. And so a bit more pressure on the dollars per appointment per person that you're seeing. So an interesting other dimension, the commonalities in the contexts and how they might be playing out differently depending on human and animal healthcare. So looking more kind of macro, there's some interesting perspectives here also. So Professor Cabinet, you can see that I haven't been very creative with my pseudonyms. I just look around the room and decide what to call someone. And that's how we ended up with Professor Cabinet. And they're a researcher, animal research, vet clinics, and they're commenting about the big considerations here in animal health. I think some of it's definitely driven by cost. It's cheaper to give an antibiotic than to do diagnostics. There is that some element of, they've come to see me, I need to give them something. Even if an antibiotic's not appropriate. So Convenia, which is a third generation cephalosporin small animal vets can use, comes in a bottle, right? And you've got to use it up. When they first released it, it was a very short period of time. And then I think they have extended the shelf life. But even so, you've got this one bottle that's open. You should only be giving it when you have a culture insensitivity result that says you should be giving it, which they're ignoring. And it's a drug. You give one injection. You give it every 2 weeks to a dog or a cat. You've got a bottle open. You've got to use it. You can't have that going off in the fridge because that whole bottle's very expensive. And lastly, another prof, UK perspective this time, thinking even more broadly about economic systems and AMR. But it's just about its economics. There's this thing about taxing and incentives, isn't there? So if you talk to economists, so why is it that we all pay tax on fossil fuels? It's because of the external costs of using those, isn't there? So why does it cost livestock producers pennies, to buy these antibiotics? Why are they so cheap when the external cost of them becoming unusable is so high? maybe you should have 1,000% tax on antibiotics. They would stop being used as growth promoters in agriculture overnight. And actually, we know that you don't need them. Antibiotics prop up unsustainable, unsanitary production systems at the expense of what? And for what? It reduces the cost by somewhat, but what are the real costs? What are the societal costs? We're told by the O'Neill Review that it's $100 trillion by 2050. So, stick that on the cost of antibiotics. So I think these perspectives lead to kind of these conclusions. I'm really interested to know how you're responding to these. So 4 or 5 comments I want to make as a way of drawing this together. The micro and the macro and the immediate and the long term economic considerations are potent forces in prescribing. I think this qualitative work is showing that. And at this potency is, even though Australia is a high regulation, high income prescribing environment, so despite all of our affluence, these economic cost situations are percolating around how we use antibiotics. There seems to be tensions here. So these economic effects seem to produce tensions with trust, expertise, the compliance on the consumer's basis, the well-being of the prescriber, etc., and so forth. There are tensions here in the material. I want to say also that these economic effects, operate and combine and settle differently in different settings. And I also think they're subject to rapid change. So even our practitioners are noticing differences and our consumers are noticing transformations. So I think these economic systems, as complicated as they are also transforming before our very eyes. And I'm not sure that national strategy is actually really addressing these dynamics. I think I'm onto something. I hope I'm willing to, understand your perspectives on this, but I think there's something going on here about the micro, macro, short, long term, and how a national strategy can address it. So the graphic here is sort of on purpose because I don't know about you, but I'm getting these Twitter feed ads asking me to go online to get my scripts. So the space is shifting, and whether or not it has real effects, it's certainly impacting on how consumers operate. And these online doctors, who are they? How do we get to understand what's going on for them? So that's the paper, and I'd be really